Hello, I'm Yeng Felipe Butler, founder and managing partner of Chestnut Run Capital Partners, here with a very special member of our advisory board, Dr. Marcy Carty. Today, we want to talk about one of Chestnut Run's three sectors of focus, human health. Marcy, Dr. Carty, brings invaluable perspective to this aspect of our investment thesis. She practices palliative care and hospice medicine and is the president and chief medical officer of My Laurel, a pioneering healthcare delivery organization specializing in providing acute care services in the home. Welcome, Marcy.
Thank you. Thanks for having me.
Oh, gosh, with pleasure. Could you tell us a little bit about how you ended up in this profession?
Yes, I started life as a management consultant, working with hospitals and physician groups, and became really enamored with how patients flowed through systems. Worked with a lot of physicians, and what I found was if I really wanted to change healthcare from the inside, I needed a medical degree. So I went back to medical school, really not thinking I was going to be a practicing physician, and then fell in love with that. Long story short, ended up doing my residency here in Boston, fellowship training here, and I've spent about 10 years working in hospitals, was a chief medical officer of a hospital, and then moved on to what I call my retirement career, the more fun career, which has all been about keeping people out of the hospital. So how do we as a population, and it's now population health, keep people healthy, keep them in their homes and keep them out of the hospital, the place I used to love and wanted to fix. And so, really my career spanned startups, a healthcare insurance company where I really got to see what kind of levers can a payvider pull, and then from a startup perspective, thinking about high risk, high complexity patients who often, if they show up in the emergency room, just get admitted because it's what the conveyor belt says will happen.
So in many conversations that we've had as we were leading up to hone in on this in part of our investment thesis at Chestnut Run, we talked a lot about aging in place and palliative care. And I read most recently in an AARP survey that greater than 70% of people ages 55 to 75 have a strong preference for aging in place. Can you set the landscape for us and what does that scene look like today? And perhaps maybe have some perspective on what it might look like in 5 to 10 years.
Yeah, so I've seen that number, and I've seen it as high as 92%. So
Wow.
It's really going to be, the vast majority of people, baby boomers and younger, have seen their parents age in a way and die in hospitals or die in a nursing home. And I think many of us have started to talk about is that how we want to age. Do we want to age in assisted living and then move into a nursing home and die in a place that doesn't feel home? And I think what you're seeing, whether it's 72% or 92%, it doesn't matter. It's a lot of people. And we're entering into a time where many people call it the gray tsunami, right? So our whole population is aging. We're having less children. More and more people are saying, I might want one, I might not want any. And so our population is aging. And so we're turning more and more upside down. And as people want to be in their home, we need to figure out how do we deliver more care into the home rather than pulling people into a place where they really lack power. I think a big piece of healthcare is the second you put a healthcare gown on, you enter the hospital, you put a gown on, you feel like a patient and not a person. And many people want to be people. And in your home, your experiences, your pictures, your surroundings make you feel like a person, and you have a lot more power, and people deserve that. And so we need to figure out how to bring acute care to people rather than forcing them into group living situations.
Let's talk more about that, because I really want folks to have a visual representation of what this could look like, right? If you can envision what aging in place with grace looks like. Can you describe that a little bit?
Yeah, I think some cultures, that means moving in with your children. You know, the U.S. has started to do a lot more around auxiliary dwelling units, letting people have a second unit in your, you know, backyard, which may allow for either children to live with their parents, but separately, or parents to temporarily move in with their children. But I'd say kids now are going international, and you know, for those people who choose not to have children, they don't have that same kind of community. And so we are struggling in the U.S. to really figure out, like, what does that mean? Who's going to take care of somebody in the home? And there's some people who are lucky, right? The top 5% maybe can afford to pay an hourly rate for someone to be there 24 hours a day. But that is not the societal answer. We don't have the money, nor, frankly, the workforce to enable that. And so we have to start thinking about technology. We have to start thinking about maybe it's not an individual home, but it's a place where your home is off of a main place that, you know, allows for some sharing of capabilities. And then, you know, I don't know, as AI, we'll have more robots, we'll have more remote patient monitoring that is not as in your face as a lot of the technology is today.
And one of the other things that I think you mentioned in our earlier conversations, but you alluded to just now, is this whole notion of community and aging in a place where you do have purpose and you have other people around you. Can you talk a little bit more about that and your thoughts?
Yeah. So there's a network called Village to Village, which is probably one of my favorite things to read about, where neighborhoods have collectively created this institution called Village to Village. Started in Beacon Hill, right here in Boston, and it allows people to pay into a central kitty of money, and allows people who have certain skills to say, I'll volunteer my carpentry skills, or my muscles, or my time, or my car, to help take care of other people in my neighborhood, right? And so as a aging senior, you may need your TV moved, and it might be easy for me to do. But as, you know, 30 years go by, I might not be able to do that. And so if you're part of one of these areas that have a Village to Village, somebody else from the neighborhood comes over and helps you do that. And it's safe, right? Because it's a neighbor, someone that somebody else trusted and allowed into the Village to Village. And the outcomes have been incredible, have allowed people who don't have family around, maybe living by themselves, in a walk-up, to have food delivered, to have someone go with them to a physician appointment, allowed them to move something, or, you know, when the time came, you know, to have someone with them as they were dying.
Yeah. Wow. It's, you know, I have a mom who is 92 years old and thriving. And I think about, you know, what she has around her. She has community, she has family, she has the ability to travel, which she finds real reward in. You know, if I think about that, and hashtag goals for me at some point when I reach that age, everything you've described is what I think most people want to aspire to have, right? Let's shift gears, because I do want to pick your brain a little bit in terms of where the areas of opportunities are, from a, you know, investing standpoint, from a supply chain, but I'm just, apart from going deep in specific companies, I'm curious to have your thoughts and insights on where are the areas that you are excited about in growth, right?
So human health is going to change in the next decade more than, I think, any other area and any other time. The genomics that are going on, so the therapies that we're going to have, are incredibly exciting. Also, society, as I just said, is going through tremendous change as we age. And so the things I'm really excited about are things that really, again, help people live healthier, and help people live longer, and help people live in a place they feel comfortable. And so if you think about AI, you know, the other piece I guess I should add in is just as we think about a workforce, right? The workforce to give the medications, to provide the care, and to allow people to live healthier is shrinking. And so we're going to need to figure out, like, how do you use each person skills at the top of their license. We've been really trying to do that from a physician standpoint, but we're going to need to do that from a nurse, from a speech therapist, and from others. And so how we train people, how you give them point of care, kind of AI assisted diagnosis, is really going to enable us to use and multiply each of our current workforce. So that kind of goes underneath all of those. But as you think about therapeutics, there's a lot going on now just with personalized therapy. And so that in and of itself, I think, is something we could talk for hours about. But it's really going to allow us to cure things we've never been able to cure. And it's going to allow people to have a much better quality of life, less side effects, because they have the right medicine that works best for them. As we think about aging in place, there's going to be a lot more equipment. There's going to be a lot more monitoring, but again, like right now, it's all wearables, and the last thing anyone wants to do is to wear a personal like emergency response button. Hey, remember the lady, I've fallen and I can't get up, right? And you're like, you've got a button. No one wants to wear that. That button says, I'm old.
Yes.
Right? And what I don't aspire to do is to look old. I aspire to look like my daughter, right? And so these wearables are going to change. They're going to be more beautiful. And they're also going to be hidden in a home in a way that someone may not even know they're there. And so all of that monitoring is also going to allow us to find things earlier. Things won't be quite as acute when we find them. And it also allow us to intervene earlier in the home. And so the things I've started to see also are things that allow mechanically for people to get to the bathroom easier and to maintain your dignity in a way that doesn't force you to have someone else do, things that like we do to babies, but you wouldn't want to have done on the other side.
Yes, that's the aging in grace. With grace piece that I was alluding to earlier can encompass so many different things, right? And for different people. If we were to fast forward 5, 10, 15 years, as this great shift in the demographics happen, what would you like to see first and foremost?
I think the first thing I'd love to see is for people who are really good at design and thinking about sociology and the way people live, to really start thinking about communal living, but in a different way. And that is not room after room after room that almost looks like a dorm, but a place where, as aging adults, we can live separately, but also have the joy of a central communal space. And whether that means I choose to eat in my own home or I can eat together, but it reinforces the idea of community, but still allows me to feel like I have my own space and my own home and my own things. And that could be multiple houses all in one space. But I think we really need to redesign this idea of assisted living, and also think about how you bring multi-generational ages together, right? So as we think about assisted living, and your mom is like someone I aspire to be. My husband's grandmother was in assisted living for 25 years, died there at 96. And all she said was, for the past 25 years, every year I make a new friend and that person dies. And so the idea of having 20-year-olds and 30-year-olds living with 70 and 80-year-olds allows for purpose in a very different way. But we have to think of how we build differently. Can't be apartments with walk-ups. And it can't be elevators that don't allow a wheelchair in. And so we have to think differently from the ground up about how we build and what kind of buildings we have. Once you do that, then you can start thinking about what kind of things can we put in place, again, to like allow someone to have dignity. But it really starts with what we're building.
As you know, Marcy, the investment team and I get very excited around portfolio companies that have very specific places that they are contributing in the overall ecosystem. So whether it's supply chains, whether they have assets to pledge as collateral. I'm curious to hear your thoughts around the pragmatic application of what you described in a hospital setting, in these assisted dwelling unit settings, Where are the opportunities there for us to actually provide capital?
Yeah, it's a really good question. Let me just provide one, thesis, and that is for anyone who opens a paper now, they'll see that hospital capacity is at 150%. So on
Did you say
any one,
150?
I was exaggerating, but yes, it's probably about 105%, but it's only going to get worse, right? So we have a limited number of hospital beds in the United States. It's significantly decreased over the last 20 years, and over the last 5 years, in particular, rural hospitals are closing at an incredibly fast rate. And so we're just more and more constrained in having enough beds for the people that need them. The other issue is as we age, more chronic conditions, more people end up in the hospital. And so on any one day in a lot of major cities, there's 50 people waiting in the emergency room to get a bed upstairs in the hospital. It costs twice as much to sit down in the emergency room waiting, and it's worse quality. And it's not fun. In general, they're cold and you don't get very much sleep, and you don't get all the medications you need. So we need to solve this, and the way to solve it is not to build new hospital beds. Frankly, new hospital beds are about $2 million a bed from a build perspective. And even if we can build them, we're not going to be able to build them fast enough. So we need an alternative, and that alternative we've already talked about is bringing things into the home.
Yep.
And so whether a home is a assisted living or my vision of something that looks different than even today, we need to be able to bring diagnostics and therapeutics into the home. And so what does that mean? It means in the past we've had to go to a hospital to get a CT scan. Yeah. We've had to go to an MRI, a Shields MRI, somewhere else outside of the home to get an MRI. If you need a blood test, you get in your car, you go somewhere else, they take your blood and they run it on a machine. And so with technology, we have the opportunity, and it's moving really fast, to bring all of those into the home in a luggable format, right? Like I can put it in the back of my car, I can bring it in the home in real time, I can tell you this is what your blood levels are, this is a broken bone, and I can treat you in place. And so for all of that kind of care journey that is very disconnected in the past, if I can bring it to you, and I can get it all done at once, it allows for me to treat people much faster and for you to do it in a place that's convenient. And so I think this is an incredible place where the Chestnut Run thesis can really impact.
Great. On that very hopeful note, thank you, Marcy, for your insights today. And I hope that was helpful in assessing our views at Chestnut Run Capital. Thank you very much.